Hello, my dear. I'm Dr. Alaa Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University. The topic of my lecture today about prelabor rupture of membrane. So, what we want to discuss today: the definition, epidemiology, risk factors, etiology, how to diagnose, and lastly, the treatment. Okay, let us start with the definition of prelabor rupture of membrane, and its abbreviation PROM. It is defined as rupture of membrane before the onset of labor. Another important expression is called preterm, prelabor rupture of membrane, PPROM, which is defined as rupture of membrane before the onset of labor and before 37 weeks of gestation. Okay, so when we say PROM, we mean that the membrane is ruptured before onset of labor. When we say PPROM, we mean the membrane ruptured before labor and before term, okay, before maturity of the baby. And all of us know that the maturity starts after 37 weeks gestational age. So before maturity means before 37 weeks gestation. Okay, what about the epidemiology? The occurrence of BRM approximately constitutes 8% of pregnancies, while the preterm one, the preterm BRM, complicate about 2 to 3% of all pregnancies. And you should know that it is twofold more common in African American. Okay, what about the risk factors? Risk factors include second and third trimester vaginal bleeding, uterine overdistension like multiple pregnancy, like polyhydramnios. Patient has a history of previous preterm pre-labor rupture of membrane, short cervical length. The patient documented that she has a short cervical length. Some nutritional deficiency like copper and ascorbic acid is considered risk factors. Also, low body mass index, connective tissue disorders, low socioeconomic status because of malnutrition and high risk of infection, vaginitis, and badly managed cigarette smoking and illicit drugs also considered risk factors for BROM. So what about the etiology? The etiology may be idiopathic, or there is a physiologic weakening of the membrane combined with the forces caused by uterine contraction. So there is two factors here. There is weakening, physiological weakening in the membrane, and at the same moment, there is forces caused by uterine contraction. So this facilitates the rupture of membrane. Also, intra-amniotic infection with release of cytokines and inflammatory materials that cause damage to the amniotic membrane. How to diagnose? From history, physical examination, and the investigation. From history, you should take a complete or comprehensive history taking, starting from personal and social history, going through the obstetric history with previous occurrence of BROM in previous pregnancies is important. Also going through a family history of similar conditions, also of past history of surgical operations and history of drug use or history of exposure to trauma, and so on, so on, so. Okay? So you should take complete history. Then the present illness should be analyzed, and you should ask about the contractions, any uterine contractions. You should ask about the fetal movement. You should ask about the time of possible rupture and the characters of the fluid, the gush of fluid per vagina. What is the color? It is watery or not? What is the odor of the fluid? Is it associated with vaginal bleeding or not? Is it associated with pain? Is it preceded by sexual intercourse? Or there is history of recent trauma to the abdomen or recent physical activity? Okay? Then go through the physical examination. Use a sterile speculum examination. Very important to use a sterile speculum examination so not to introduce infection, for fearing of the risk of occurrence of chorioamnionitis. So use a sterile speculum examination and inspect for the signs of cervicitis, umbilical cord prolapse, any vaginal bleeding, and sometimes you can visualize the amniotic fluid passing through the cervical canal and pooling in the vagina, and this actually confirming the diagnosis of membrane rupture. At the same moment, you can take culture from this amniotic fluid and take sample of this amniotic fluid, as you will see, for investigations. What about digital examination? Can we do digital examination in a case of PROM? The answer is no. Don't do digital examination when it is not needed. Unless the patient in labor, in active labor, you will do digital examination under sterile condition to examine the cervix for cervical dilatation and the effacement evaluation. Okay? What about the investigation? We will take sample from this amniotic fluid or vaginal fluid for culture during speculum examination. Also, examining the amniotic fluid under microscope will show arborization and the furling sign. You can test the pH of this fluid, and you should know that the amniotic fluid is alkaline, ranging between 7.1 to 7.3, while the normal vaginal pH is acidic. It is between 4.5 up to 6. So, presence of alkaline fluid denoting this is an amniotic fluid. Okay, so suggesting to be yes, amniotic fluid, and the case is rupture of membrane. Okay, fetal fibronectin detection is another test for BROM. It is sensitive but not a specific test for rupture of membrane. As you see in this picture, this is picture for testing for fibronectin, fetal fibronectin, two lines denoting positive, one for control and one for the test, as you see, simulating that of pregnancy test, but here we are testing for fetal fibronectin. So two lines denoting that it is a positive test. It is sensitive, yes, it is sensitive, but not specific. Also, fetal fibronectin can be used for prediction of preterm labor also. Not only for PROM, but also for preterm labor. In the other picture here, this is the use of nitrazine paper test for pH of the vaginal fluid. And we said amniotic fluid is alkaline, while normal vaginal pH during pregnancy is acidic. Another test is called ROM plus. This is to detect two types of protein found in amniotic fluid: alpha fetoprotein and the insulin-like growth factor binding protein 1. okay, using the unique monoclonal polyclonal antibody approach. Okay, as you see here in the picture, from 4 to 6 drops of vaginal fluid is what is inserted here. Then you test, you find here the positive test, as you see, with 2 lines, the negative test here with 1 line for control. As you see, this is another test for PROM cases. Ultrasound, yes, is very important, and you should measure the amniotic fluid index, also any single pocket of amniotic fluid. And of course, you can diagnose oligohydramnios if amniotic fluid index in 4 pockets, in 4 quadrants, less than 5. Also, you can use ultrasound for fetal biometry, for measuring the biparietal head circumference, abdominal circumference, the placental side, ensure that there is no placental abruption or low-lying placenta, fetal well-being, everything, okay? Then, after a full evaluation, the diagnosis still remain unclear if you did all of the above from examination, from history, examination, and investigation, and you still query about the diagnosis of premature rupture of membrane, Prelabor rupture of membrane. Then you can do another test by inserting a dye inside the uterine cavity called the indigo carmine dye, guided by ultrasound. Then give the patient tampon or use a pad externally and let her move for a few minutes. Then if you found the pad soaked with the blue dye, this denoting that there is prelabor rupture of membrane, because the dye pass from inside the uterine cavity in the amniotic with the amniotic fluid through the cervix, through the vagina, and the pad becomes soaked with this dye. Rarely we need this test, this invasive test, because from other items of history examination and the investigation, we can reach the diagnosis easily. What is the differential diagnosis of prelabor rupture of membrane? Urinary incontinence. Don't mistake the soaked urine in the pad or in the panties of the patient with the amniotic fluid. Of course, the urine has its characteristic odor. Also, from urogenital tract trauma, vesicovaginal fistula, lower urinary tract infection, from vaginitis, with different types of discharge according to the organism. Each one has its specific characters. From Crohn's disease and from rectovaginal fistula. Okay, what is the complication of PROM? Perinatal mortality, yes. Respiratory distress syndrome in infant. Infection like chorioamnionitis, which is very risky and can be complicated by septicemia and causing even mortality. So it's something important as regard to the mother and to the fetus, hazardous for both. Intraventricular hemorrhage for the baby, fetal lung hypoplasia, and the risk for cesarean section delivery due to PROM. What about the treatment? Management of PROM is determined by the gestational age. Let us understand this point. If we have early term and the term patient, those above 37 weeks gestational age, you should proceed to delivery and give prophylaxis for Group B streptococcal infection. Okay, so early term and the term proceed to delivery. Late preterm, which include gestational age from 34 up to 37, proceed to delivery, as in case of early term and the term. Okay? Okay, to avoid complication of BROM. What about if gestational age ranging between 24 up to less than 34? Here we can do expectant management, giving antibiotics to the patient like erythromycin in a certain regimen, single course of corticosteroid including betamethasone 12 milligram, one dose and another dose after 24-hour intramuscular, or use dexamethasone 6 milligram given intramuscular every 6 hours for 4 doses. And you don't repeat the course, only single course, either betamethasone or dexamethasone. Group B streptococcal infection prophylaxis is important. Administration of magnesium sulfate to reduce the risk of cerebral palsy and other neurological insult for the baby is important also, so long as the baby is less than 32 weeks gestational age. If complicated by infection, you should terminate the pregnancy, and the delivery is a must. If the baby is less than 24 weeks gestation, you should counsel the patient about that, because the prognosis in such a condition is very bad. As regard to the fetus, the possibility of intrauterine fetal death, possibility of congenital anomalies, multiple congenital anomalies is high. The possibility of perinatal mortality is very, very high. So this is carry a bad prognosis if preterm prelabor rupture of membrane occur before 24 weeks gestation age, and you should explain to the patient all about this. On the other side, also maternal complication is high, risk of infection, chorioamnionitis, septicemia, and so on. Okay, so you should explain everything to the patient and counsel her for termination. And by the way, you should know that it is not allowed to give group B streptococcal prophylaxis or corticosteroid or tocolysis or magnesium sulfate before viability of the baby. And the medical legal viability in different countries vary. In USA it is 20 weeks gestational age, in UK it is 24, in Egypt it is 28. So before that we consider it as a miscarriage. Okay, so termination as a miscarriage, if before medical legal viability, can be done after counseling the patient. If the gestation age is less than 24 and the patient insists to continue her pregnancy, you should do expectant management and give her antibiotic prophylaxis because she wanna to continue her pregnancy. But you should explain to her all the others for her and for her baby. What about the admission to the hospital? Really, patient with preterm BROM should be admitted to the hospital with periodic assessment for what? For infection. It's very important. For risk of chorioamnionitis. For the diagnosis of placental abruption, if it is present. For diagnosis of umbilical cord compression, and for evaluation of the fetal well-being, and labor diagnosis if it happened. And you should do periodic ultrasound evaluation. Why? To monitor fetal growth. Also, you should do periodic fetal heart rate monitoring. Okay? Okay. What about the vital signs? It's very important really in a case of PRM, especially measuring the maternal temperature, which when increased, the temperature is increased, this raises a suspicion of intrauterine infection, and you should confirm if there is infection or not, because infection means I should terminate the pregnancy and I should deal with it seriously. Okay? Of course, with giving the patient broad spectrum antibiotics. But no conservative treatment if we have infection like chorioamnionitis. We should terminate pregnancy, regardless the gestational age. Okay, during expectant management in hospital, you should do serial monitoring for leukocytes and inflammatory marker. In the past, yes, we did that. But currently and recently, it was found that it is not specific for diagnosing infection, because these leukocytes and C-reactive protein, these can be increased due to other reasons rather than amniotic fluid infection like chorioamnionitis and so on. So it is not specific. Okay? So depend mainly on clinical signs of infection, then you can prove it or confirm it by doing CBC for leukocytosis and ESR and C-reactive protein to confirm. Okay? But don't use it as a routine for serial monitoring. Okay? Okay. If at any time we have non-reassuring fetal status by fetal well-being tests, we should enhance delivery and terminate the pregnancy to save the life of the baby and to avoid complication. If at any time we diagnose the chorioamnionitis, we should terminate the pregnancy because it is dangerous to the mother and to her baby. And this is the last slide, and thank you. I'm Dr. Ala Musbah, Professor of Obstetrics and Gynecology, Faculty of Medicine, Mansoura University.